Good evening, everyone, and welcome to Mahamana Pandit Madan Mohan Malvi Cancer Center. And for our podcast today, we have Dr. Richa Vaish, and she's a professor in head neck surgery at Tata Memorial Hospital, Mumbai. Welcome, Dr. Richa.
Thank you, Dr. Aseem.
So, I would like to introduce that we are having this podcast on the management of the early oral cancers, and I believe that is your forte, and in which we are going to have a very enriching discussions today. So, for our audience, I would like you to please briefly tell us what is a neck dissection, what is a selective neck dissection, and how do we classify various types of neck dissections.
Neck dissection is a surgery that we perform to address the neck appropriately in any neck cancer, and it's very, very important to decide what should be the extent of dissection. Now, selective neck dissection is basically performed in the scenario when it is a node negative neck. And when I say a node negative neck, I mean it has to be clinically and radiologically node negative. And in this scenario, we can get away with a selective neck dissection, which nodal cavity is supraomohyoid neck dissection carried out level 1. You can further classify it whether you are offering it to the node positive or a node negative neck. So you may have the extent of dissection based on that. And also it varies with a subside. Say it's a oral cavity, hypopharynx, oropharynx. According to that, you can decide what should be the extent of selective neck dissection.
So, for the audience, especially the scientific, because there are a lot of residents that will be listening to this. So, tell me what is the advantage of doing a neck dissection in oral cancers, and if we can avoid it.
So even if it is a clinical radiologically node negative neck, nearly 30% of the patients would have occult nodal metastasis. And if we don't attend to these metastases appropriately, they come back with a lot of vengeance and we see N2B and 3 disease. And 50% of them would succumb if it is not addressed appropriately at the time of first surgery. So even if it is a node negative neck, say a small cancer, there is no getting away from the neck section and we should be very well versed with it and offer it to all our patients.
So when we do a neck dissection in a node negative neck, so what is the benefit that we get? What is the survival benefit that adds on to that?
So we have a landmark publication from our institute, which has been published in NEJM in 2050, in which we showed in 496 patients that if you offer an elective neck dissection, there is a survival benefit of 12.5% compared to the weight watch approach. So that is why it has now become the standard of care in cancers.
So once again, that's a very important point she had made, that the survival advantage of 12.5% in patients in which the neck is addressed. And therefore, addressing the neck is very important because it improves survival. Now, my next question, since this trial was there have been several meta-analyses as well that have shown that the benefit of neck dissection is there. However, there are certain studies who have said that the depth of invasion, if it's less than 3 millimeter, we can avoid the neck. Then there's a SENT study which have compared. Then there's a meta-analysis as well that has compared the elective neck dissection versus the SENT. So, what is your opinion and how are those calculations? Can you please? I think you also have a publication and a comment on the same.
So when we talk about the cutoff, this was basically there to decide the extent of the neck dissection. But as you're rightly putting it in the right perspective, it can be 3 mm, it can be 4 mm, it can be 5 mm. The answer is 5. Our paper says 3 mm. There will be papers suggesting 4 mm as well. The major limitation with the depth of invasion when we talk is that we don't have it pre-operatively. All we have is a biopsy. So you cannot get it done and decide based on the depth of invasion whether you are addressing the neck or not. And even if many centers would not have a frozen section facility. Even if you have it, it's just one section. So whether it's the accurate DOI, it's a contentious issue. So because of all these limitations, it is a safer site. Is to do the neck dissection at the time of surgery itself.
So, can you briefly tell us, like, if you compare the elective neck dissection study and the SENT study? So, what are the key differences in those studies which will point that elective neck dissection is superior to observation?
So basically, both the studies have shown that there is nearly 12% survival benefit with SENT trial, 20.5% with our trial. But the basic difference was that in the SENT trial, the benefit was also observed in the thinner tumor, whereas in our trial, there was a lack of benefit in the tumor. So from that, the uniform finding was that it should be offered to all. Second thing is that even though the trial was calculated with a very good power, but they could not complete the recruitment because once this was published, obviously there was a problem, ethical issue with the trial, so they had to prematurely terminate the trial. So if you look at them carefully, it's half the cohort which is a randomized cohort and rest is a real world cohort that they have taken into consideration. So that's the two major difference when we compare the population with ours.
So, a scientific and a philosophical question I would like to ask you. So, if there was a SENT trial, it was an elective neck dissection trial. Now, what was the change in philosophy of the management after the SENT study, and does it lay down the foundation for further sentinel node biopsy studies, or was there some impact on them?
Okay, so there are two trials. So one is the SENT trial, which I was alluding to before. It was Ian Hutchison trial, and now the question is being asked about the SENT trial.
I'm asking about the SENT trial. So, how does the SENT trial impact the sentinel node biopsy trials?
the stent trial.
How did that impact it?
So before the publication of the stent trial, we all knew that the sentinel node biopsy has a good diagnostic accuracy. We knew that the negative predictive value was upwards of 95%, but we did not have any trial which has shown the oncological outcomes with the sentinel node biopsy. So SENT was the first trial in which, for the first time, based on the sentinel node biopsy, they actually spared the neck. So if the node was negative, the neck was spared, and then they followed up and reported the 3 years disease-specific survival, which was around 94% in these cases in 450 patients that they analyzed. So that was the first robust data by which we gained confidence that probably sentinel node biopsy is oncologically a sound procedure.
So I'm just taking forward from there. The SENT trial showed the benefit of using sentinel node biopsy. And then the Garrels and the Hasegawa study took place, and they also established certain things. So briefly tell us what was the impact of these both the studies, the French and the Japanese study. And then I would definitely come on to the philosophy of the sentinel node biopsy.
So when SENT laid down the foundation for considering the sentinel node biopsy in this setting, the first head-on comparison was with the Garrel trial, which was published towards the end of 2020, which showed that the 2 years and 5 years neck node recurrence-free survival was very, very similar in a sentinel node navigated neck dissection compared to a elective neck dissection. And similar findings were also offered by the Japanese trial, in which they looked at the 3 years overall survival, again extremely overlapping curve. So both these trials actually for the first time established the oncologic safety of this procedure, comparing with the gold standard, which was a elective neck dissection.
So now you are on a mission towards developing and setting up for sentinel node biopsies in different centers. You're on to teaching of sentinel node biopsies. So now, based on those findings and based on the experience of your starting a sentinel node biopsy trial, so what are the major challenges that you face and how are you planning to overcome them?
So the first and foremost thing is, as I always say, it's a teamwork. You need three departments, three dedicated departments. One is the nuclear medicine, the surgery department, and the pathology department. Now, there is a learning curve for the procedure, and it is same for all the three departments. So there is the requirement for credentialing is across all the three departments. The major hindrances, of course, one is you're learning the surgical procedure. That is fine. It's not all that difficult because if you're oriented with the neck dissection, you would be able to identify the neck nodes. However, we should keep the principles in mind because if you are doing a sentinel node biopsy, which is not appropriately done, it is same as leaving behind the disease if you're not addressing the neck. Something like wait and watch. And if this neck fails, 50% of them will succumb. And the ones, even if you try to salvage, the outcomes will be very, very favorable. The second hindrance is at the level of the pathology department because it's a very, very labor-intensive protocol. So at our center, where we have the infrastructure facility available, but looking at the volumes of work that we have, it's extremely difficult then to get such a exhaustive protocol executed in the pathology department. So I think these are the two major challenges. Apart from that, cost effectiveness is a concern because requirement of the two procedures, one extra procedure from the nuclear medicine department, and then extensive pathological processing with the IHC that adds to the cost. And from the nuclear medicine department, sometimes if there is a lack of supply of the nanocovid, could be a limitation for the nuclear medicine.
So we understand the limitations and we are into developing and enhancing the sentinel node biopsy efficacy as well as utilization. However, by the time we establish that and we start using in routine practice, at present, what shall be the advice to you for the residents?
So to residents, I'll say it's a very simple procedure, but don't directly jump onto the sentinel node biopsy. First, perform adequate neck dissections, understand the anatomy. So it is a node biopsy, but you see you're going to the level 2. A node is overlying the IGV. It's a very limited space where you're working. Unless you have the full orientation of the anatomy, there is a possibility that you may injure the surrounding structure. So instead of actually decreasing the mobility, you may actually add on to the mobility. And then go the right way, observe all the procedure. Don't just be looking at the surgery. Go and see and understand the principles of the nuclear medicine, perform the surgery then and go back and see how they're doing in the pathology department so that you understand it as a complete picture and not only the cell. And then complete the learning curve and then go ahead and maybe it is a signal spare the neck dissection once you are 100% sure that you are identifying the correct sentinel node and not.
So now coming back to the question where we started. So we are doing a selective neck dissection. So what are your indications on advising a selective neck dissection?
So selective neck dissection, by and large, the standard indication would be a clinico-radiologically node negative neck. So that would be selective neck dissection. There is also the emerging role of performing the selective neck dissection in a low volume disease, like N1, a single node which is small in size. But it comes with a caveat. These patients, if you look at the Liang meta-analysis, need a post-operative adjuvant radiotherapy. So even if you're not completing the neck, probably there's a consideration of adjuvant radiotherapy setting, if particularly there are high-risk features present in the pattern.
So thank you so much for your valuable points. And for the audience, I'd like to just summarize all the points that we have discussed. It's very important that we manage the neck in all early oral cavity cancers. So as of now, the treatment of choice is surgery of the primary, that is a wide local excision, followed by a selective neck dissections, at least a level 1 to 3 or a level 1 to 4 if you are planning for an extended neck dissection. If the node is positive, then you are supposed to do a modified neck dissection. If you are planning to do a sentinel node biopsy, you must be trained, you must be well versed with the technique, and you must have the infrastructure, and then only you proceed for a sentinel node biopsy. Thank you so much.
Thank you so much.